This is the Oropharyngeal Dysphagia project by Monica, Alex, Chandani, Richard, Samantha, and Derek. So what is oropharyngeal dysphagia? It is the difficulty in either the oral or the pharyngeal phases of swallowing, such as in chewing, initiating the swallow, or propelling the bolus through the pharynx into the esophagus. It is caused by multiple neurological, structural, or other medical conditions. Oropharyngeal dysphagia arises from abnormalities of muscles, nerves, or structures of the oral cavity, pharynx, and the upper esophageal sphincter. For the gross CNS and PNS anatomy involved in oropharyngeal dysphagia, we see that the voluntary initiation of swallowing takes place in special areas of the cerebral cortex of the brain called the precentral gyrus, also the primary motor area, the posterior inferior gyrus, and the frontal gyrus. Information from these areas converge in swallowing center in the medulla, which is part of the brainstem. The medulla is a relatively small area in the brainstem that contains multiple structures that are critical in carrying out the swallowing reflex. So strokes that involve the medulla are especially likely to cause swallowing problems, such as the oropharyngeal dysphagia. There are three types of swallowing. There is the subconscious, there is the reflexive, and there is the nutritional or volitional swallowing. When volation is involved, there is a swallowing network in the cerebral cortex that includes the insula, cingulate gyrus, prefrontal gyrus, somatosensory cortex, the prenuncius regions, and all of these areas are activated when a person takes a volitional or nutritional swallow. When a person has a stroke, one or more of these areas is usually damaged, which disrupts the swallowing network and debilitates the command center. Therefore, swallowing becomes impaired. Dysphagic symptoms can also occur if a stroke affects the brainstem, such as with the lacunar infarcts of the brainstem or a hemorrhage in this region. Any neurologic or muscular damage along the deglutitive axis can cause dysphagia. Central causes of dysphagia in stroke patients include damage to the cortex or brainstem, and peripheral causes include damage to the nerves or muscles involved in swallowing. Swallowing abnormalities can develop with these damages result in a malfunction, discoordinated function, or lack of function in the neuromuscular apparatus. Lesions in the medulla causing both dysphonia and swallowing disorders with aspiration involve the lower middle levels of the medulla in the inferior dorsolateral and mid-lateral regions, affecting inputs to the motor neurons of the laryngeal, facial, and soft palate musculature. Thus, the cortical control of swallowing may be involved in the volitional control of the oral phase of swallowing, involving bolus manipulation and chewing, and the initiation of the pharyngeal phase. On the other hand, brainstem control involves the patterning of the pharyngeal phase and the premotor inputs to the pharyngeal and laryngeal motor neurons on both sides. A unilateral lesion in the dorsolateral medulla, situated in the rostral third of the medulla, affecting the nucleus ambiguus and the nucleus tactus soleratus with their surroundings, reticular formation may disrupt premotor inputs to both the ipsilateral and contralateral motor neurons, producing dysphagia. We see that the respiratory center controls breathing, sneezing, swallowing, coughing, and vomiting. Motor and sensory tracts from the frontal and parietal lobes cross from one side to the other in the medulla. Both voice and swallowing are complex coordinate systems that require precise integration of oral, pharyngeal, laryngeal, and respiratory musculature in the upper airway. Unotopic anomalies of the oropharynx can also cause such anomalies. The most common cause relates to the dysfunction of the upper esophageal sphincter. This dysfunction may occur because of failure of the upper esophageal sphincter to relax, or because of the lack of relaxation to be coordinated with pharyngeal contraction.
I will be covering the internal anatomy of oropharyngeal dysphagia. So dysphagia is typically associated with brainstem damage, and the swallow function requires descending sensory motor tracts, which originate from the primary sensory motor cortices and give input to the medullary swallow centers in the brainstem region. So given the importance of cortical and subcortical input via the white matter, lesions or damage has a high prevalence of dysphagia symptoms which occur in the internal capsule. So we will be covering about several subcortical areas that influence the swallow function, which includes the internal capsule, the basal ganglia, the thalamus, the insula, and the anterior cingulate gyrus. The basal ganglia receives input from various cortical areas and projects signals via the thalamus to the prefrontal, premotor, and supplementary motor cortices. The thalamus helps to provide sensory information and excitatory input essential to triggering the swallow reflex during the pharyngeal phase. The basal ganglia helps to refine and helps with the detail of fine movements required for deglutition. The indirect and direct pathways serve a purpose in the process of a swallow and provide dopaminergic information. The issues of the basal ganglia functioning can be seen in patients with Parkinson's, and that helps give an example of how movement patterns regulated by the subcortical structure affect the fine movement of a motor swallow. The next subcortical area is the insular cortex, especially the anterior insular cortex, which is around BA16, has connections to the primary and supplementary motor cortices, the thalamus, and the nucleus tractus solitarius, which was mentioned in the neuron section, all of which are important to the oropharyngeal phase of swallowing. It is shown to have some control over oral muscular coordination. It helps to initiate the swallow, modify the pattern, and takes into account the somatosensory inputs. The posterior insula has connections to the thalamus and takes in the homeostatic inputs such as pain, touch, and temperature. And these are all important to the triggering of the swallow reflex. So damage to this area can cause disruption of a sensory input, the gustatory disorders, dysphagia, dysarthria, and aphasia, and these are due to disruptions of sensory input and loss of some fine motor control. And the last subcortical area is the anterior cingulate gyrus, which can be found around the BA 24, 25, 32, and 33 area, and that's located above the corpus callosum and plays a role in autonomic functions. It has projections to the hypothalamic mammillary bodies and the anterior thalamic nucleus. It also has projections to the anterior insula, amygdala, prefrontal cortex, and the motor and premotor areas of the brain. This serves as a default system and has some implications over reflexive motor movements involved in the swallow function. Its role is small, but the damage could still cause the disruption of a swallow. And the multiple cortical impairments, mainly in the supplementary motor area and anterior cingulate gyrus, might be responsible for the dysphagia and Parkinson's disease, similar to the basal ganglia. Patients with oropharyngeal dysphagia have difficulty transferring food from the mouth into the pharynx and esophagus to initiate the involuntary swallowing process, but the patient is aware that the bolus has not yet left the oropharynx. The presenting symptoms listed below, they vary in both characteristics and severity depending on the underlying disease, state, or injury, and can range from unreported or silent aspiration to frequent throat clearing to difficulty swallowing food. So I was able to categorize the different problems and symptoms in different groups. So first of all, the first group is swallowing problems, and this includes the inability to keep the bolus in the oral cavity, difficulty gathering the bolus at the back of the tongue. There might be hesitation or inability to initiate the swallow. There's also odynophagia, and that's having pain while swallowing. There's frequent repetitive swallows and throat clearing. There's swallow-related coughs, which can occur before, during, and after swallowing, and the patient might also have difficulty swallowing solids. Some of the food problems include food sticking in the throat, chest, or behind the sternum. There might be nasal regurgitation or bringing food back up. There's an inability to propel the food bolus posteriorly into the pharynx, and there might also be food ingestion, which becomes extremely limited, which can result in weight loss and severe malnutrition for the patient. Some of the speech and resonance problems include a gargly voice after meal, a frequent hoarse voice, and the patient might also have nasal speech and dysarthria. And other health problems that might occur include respiratory problems such as recurrent pneumonia or upper respiratory infections, and the patient might also have frequent heartburn. A person with oropharyngeal dysphagia usually gets a referral to a speech or swallowing therapist, an ENT, a gastroenterologist, who is a doctor who specializes in treating digestive disorders, or a neurologist, and they provide therapy techniques such as exercises that can help coordinate swallowing muscles or re-stimulating nerves that trigger the swallowing reflex. And they also help teach swallowing techniques, so the patient can help find ways to place the food in their mouth or have different postures or positions of the head or the body to aid swallowing processes. Some example of these possible therapy techniques include a head tilt, which helps move the head to a better side so the bolus is redirected through the oral cavity and the oral bolus transport is improved. Another example is a chin tuck, where the patient puts their chin down to move the bolus anteriorly. So that prevents the premature spillage and widens the folliculae, so the spillage hesitates there, so it gives more time for the vocal folds to close, thereby reducing the risk of aspiration. Another example of a possible therapy technique is a head back, which helps bypass the oral stage by utilizing gravity to clear the oral cavity.
The main cranial nerves that innervate the sensory and motor anatomy of swallowing are the facial, trigeminal, hypoglossal, glossopharyngeal, and vagus nerve. Dysphagia is the difficulty or disruption in any of the phases of swallowing. In more severe cases, we'll have oropharyngeal dysphagia, where there's disruption in the oral phase and pharyngeal phase. And I will explain the cranial nerves that most pertain to each phase in the next slide. The oral phase of swallowing mainly includes voluntary movement, and consisting of biting the food, chewing the food, making a bolus, and pushing it back to the oropharynx. For the facial nerve in swallowing, we're mainly talking about the motor movements of the buccinator and the orbiculus oris. The buccinator will assist with bolus control by compression of the cheeks and helping move it through the oral cavity, while the orbiculus oris will help with the retention of food by not letting food fall out of the front of your mouth, by closing your lips and pressing them against the teeth. The facial nerve will also assist with glandular secretion from sublingual and submandibular glands, helping moisten the food. The trigeminal nerve is going to help with motor and sensory aspects of the oral phase. For mastication, the trigeminal nerve is going to help with moving the jaw up and down, side to side, by innervating the masseter and internal and external pterygoids. The sensory nerve is going to help for jaw proprioception, knowing where it's at, and also perception of the bolus inside the mouth, inside the cheeks, the back 2/3 of the tongue, and it's also going to help pushing the food back and initiate the swallowing phase by pushing the tongue up and back. The hypoglossal nerve is going to be all motor, and it's going to innervate all intrinsic and most extrinsic tongue muscles. It's going to assist in controlling the bolus in the mouth, which is essential for swallowing. This nerve is also going to assist lifting the tongue up and back to close off the oral cavity during swallowing. And in the next slide, I will talk more about that pharyngeal phase. The pharyngeal phase starts with the tactile stimulation of the oral pharynx initiating the swallow, then moving the food down through the pharynx all the way up till the esophageal sphincter. The pharyngeal phase consists of involuntary sensory and motor functions, mainly controlled by the glossopharyngeal nerve and vagus nerve. The glossopharyngeal nerve is the main nerve that initiates the swallow by the sensation of the oral pharynx and initiating the reflex of the swallow. It assists in closing off the nasal and oral cavity, and also saliva secretion from the parotid gland in the cheeks, and producing mucus in the back of the throat on the oral pharynx. The glossopharyngeal and vagus nerve work dynamically in moving the food down the pharynx and closing off all respiratory pathways so the food gets down. The vagus nerve, although consisting in closing off the respiratory pathways with the glossopharyngeal nerve, mainly innervates muscles that control the vocal folds in closing the airway passage there, having the epiglottis cover the glottis, and many motor movements and passage of the bolus down the pharynx, including the release of the esophageal sphincter, and that will begin the start of the esophageal phase. The sensation sensory components of these two nerves mainly help in the assistance of swallowing, with the sensation of pain and temperature, making sure the bolus is chewed correctly and as there's a safe passage passing through the pharynx. And the involuntary motor movements assist with the constriction, release, the closing of all the respiratory pathways, the soft palate rising, closing the velum, and the epiglottis covering the trachea. Okay, next slide. So oropharyngeal dysphagia can be mild, so difficulty in chewing, to severe, which would be difficulty in preventing aspiration into the airway. Oropharyngeal dysphagia is oftentimes the presenting symptom in other coinciding neurological degenerative disease. The leading cause of death for Parkinson's and Huntington's is aspirated pneumonia and or choking, where Parkinson's is going to be a silent aspiration for loss of sensation in the larynx and pharynx, and Huntington's is going to be hyperkinetic incoordination of tongue movements and delay in the swallowing initiation.
Neurons and physiology. Swallowing is triggered by general sensory information, which is gathered in the fascial pillars, oral cavity, and pharynx by bipolar sensory neurons, which means they have a dendrite and an axon extending on either side of the cell body. So sensory stimulation gets gathered and it activates paired swallow centers via the reticular swallow center in the lower pons and medulla. So each center will receive an afferent sensory information and it will relay that to the cortex, and it'll also gather efferent motor information, which is triggered by the sensory information of pressure, weight on those areas like the fascial pillars or the velum, which triggers swallow. An intricate system of interneurons then will kind of synthesize the information given to them by the sensory neurons and give it to the motor neurons. Interneurons are multipolar cells, so they contain many dendrites and a single axon. So they deliver the information to various cranial nerve motor nuclei, as you can see on the slide, but I don't want to butcher the pronunciations. The main afferent would be the nucleus tractus ciliaris, and the efferent nuclei giving out motor information would be the nucleus ambiguus and the dorsalis nerve vagi. The alpha lower motor neurons then which are rapid impulse conductors and also multipolar cells, will go on to innervate striated muscles and release acetylcholine at the motor end plate. The oral cavity, pharynx, and esophagus are all innervated by lower motor neurons. So the main neurotransmitter involved in swallow is acetylcholine. There are also implications that neurotransmitters such as GABA or dopamine may be involved, considering Parkinson's and Huntington's chorea, Parkinson's being a dopaminergic disorder and Huntington's being GABAergic, would have issues with movement, which can have implications for a safe swallow or improper deglutition, aka oropharyngeal dysphagia. Also, main nerves that could be damaged may be lower motor neurons, which can cause a facet paralysis of the muscles involved in swallow, and brainstem lesions, where we get the integration of the afferent and efferent pathways, can also cause major issues for swallow.
Now we're going to talk about the sensory system and tracts associated with oropharyngeal dysphagia. The trigeminal nerve is the principal sensory nerve for the face and head. It includes the mucosal membrane and is joined by fibers of facial, glossopharyngeal, and vagus cranial nerves. The trigeminal nerve innervates the temporalis masseter, the medial and lateral pertucoid muscles, and gathers information from the anterior two-thirds of the tongue. However, the facial nerve gathers taste information. The glossopharyngeal nerve gathers sensations of the posterior one-third of the tongue, the velum, and the superior pharynx. The vagus carries sensory information from the velum, larynx, posterior and inferior pharynx. Afferent signals enter the brainstem along with their significant cranial nerve nuclei while the bolus is being manipulated in the oral cavity. This results in synapsing in the thalamus and in projecting sensory-specific areas of the cortex. Prior to primary motor area executing movement, the primary sensory cortex sends information to higher order association areas for a single sensory modality. Oropharyngeal swallowing relies heavily on sensory information about the properties of the bolus and where the structures are relative to the moving bolus. Oral and pharyngeal cavities have a unique set of sensory fibers that respond to different types of chemicals, such as sweet, salty, and sour. Taste sensory fibers have terminal endings with chemical receptors. Taste is a form of afferent input arising in the mouth. Chemical receptors cover most of the tongue, palate, and pharyngeal mucosa. The pharyngeal mucosa fibers synapse in the brainstem with the nucleus tractus solitarius and travels via the chorda tympani branch of the facial nerve. Sensory disorders associated with our disorder would cause reduced awareness of oral or pharyngeal light touch and delay in triggering this pharyngeal swallowing. Difficulty in programming motor actions during swallow can also usually have a sensory component. Some tracts associated with our disorder is a spinal trigeminal tract which has projections from the facial, glossopharyngeal, and vagus nerve. The spinal cerebellar tract is responsible for unconscious proprioception from muscles of extremities and limbs. The spinal thalamic tract, which is responsible for the mediation of pain and temperature. The fasciculus cunatus is responsible for discriminative touch and vibration to the upper half of the body. Then the most important tract being the spinal trigeminal, due to the fact that it deals directly with the structures and muscles that would be disrupted in an individual with oropharyngeal dysphagia. The trigeminal nerve would be implicated in our disease, is responsible for sensation to the facial muscles, damage to the nerve would result in complications, such as ipsilateral loss of sensation in areas such as the face, rostral of the tongue, teeth, and cavities of the nose and mouth. The lingual branch of the trigeminal nerve includes the sensations for pain, touch, and proprioception of the anterior two-thirds of the tongue. The hypoglossal nerve also can contribute to complications such as muscle weakness and trouble forming the bolus, which would result in implications to safe swallowing. And the larynx carries sensory information from the vagus nerve.
The parts of the swallowing mechanism we are looking at include the lips, tongue, oral cavity, and pharynx. Any dysfunction of these structures can have an effect on the transportation of the bolus and or the airway protective functions. And dysfunctions can come about from diseases such as Parkinson's, multiple sclerosis, and Huntington's disease, or they can occur from injuries like a stroke or head trauma. This can cause symptoms ranging from aspiration, difficulty swallowing, and frequent throat clearing. In terms of looking for the structures that are affected, a modified barium swallow using a variety of different boluses can be conducted to figure out where the issue is. This gives the clinician an idea of what structures are affected and where the lesion might be in the brain. Next, we're going to go over just the basics of the motor systems that are included in dysphagia. So the first is the motor cortex, and the main function is the execution of movements with constant updated feedback from the surrounding cortical and subcortical areas. And the cortical motor projections regulate a series of movements that are complex, precise, and skilled. And some examples are dancing, running, and speaking. The next one is the basal ganglia, and its main function is regulating and modifying motor activity through suppressing extra movements. And so the projections follow the path of the sensory motor cortex to the striatum, to the GP external and the GP internal, all the way to the thalamus and the PMC. And then for our purposes, it is important for when there is another disease that coincides with it, like Parkinson's. The next one is the cerebellum, and its main function is motor planning and monitoring all motor input and output. So it's basically just an error control device. It receives input from the motor cortex, reticular networks, and spinal cord, and it has corrective outputs that are sent out if an error is detected. And this is especially helpful when doing rapid activities like speaking, typing, or running. And this is all done subconsciously. The last one is the brainstem, and its main function is to control the gag reflex and has spatial control, partial control of swallowing. It receives feedback from the tongue movements through the muscle spindles via the hypoglossal nerve. And now if there were a stroke in the motor cortex, the result would be issues with the execution of movements and a loss of precision. A stroke in the basal ganglia would cause excess movements due to lack of inhibitory control of the muscles. If the cerebellum were compromised, then the muscles would either overshoot or undershoot their target. So basically, they wouldn't match up correctly. And then finally, any damage to the brainstem can result in deficits with the swallow response. And this lack of precision and inhibitory control can cause symptoms like aspiration, difficulty swallowing, and throat clearing. The muscles are out of sync with the motor system and cannot perform their functions properly. If an individual developed oropharyngeal dysphagia due to another disease, like Parkinson's, then they would experience a lack of movement or bradykinesia due to lack of dopamine. Given this information, where do you think the lesion might be? And the last portion we're going to go over is the tracts. And so the first is the corticospinal tract, which mediates voluntary movement of skeletal muscles of the distal limbs and axial trunk muscles, and is important for balance and keeping an upright posture. Now this one's not as important for swallowing, but it's more important for respiration and just keeping your balance. The next one is the corticonuclear or the corticobulbar tract, and it controls fine movements of the facial, oral, and other associated muscles through cranial nerve nuclei in the brainstem. And nerve fibers from the left motor cortex innervate left and right nuclei of some cranial nerves, and the right side of the motor cortex controls some functioning of the cranial nerves on both sides. So that's just a random important note. And then lastly is the pyramidal tract, and this is where, the corticospinal and the corticonuclear, they get directions from the pyramidal tract. And so it's responsible for smoothness of movement, setting up motor plans, and adding judgment and planning to motor movements. And so the corticonuclear tract is our focus for this disorder because it deals directly with the muscles and the swallowing mechanism. This tract receives direct instruction from the pyramidal tract, so if it's damaged, then the patient will exhibit slowness of movement and precise movement of muscles like the masseter, buccinator, and levator veli palatini. And now here's the last portion. The basal ganglia takes motor impulses from the motor cortex and delivers them to the neostriatum, which then goes to the internal and external GP and then sends refined projections back to the cortex in a feedback loop. And the structures in the basal ganglia are all controlled by the neurotransmitters, so if damage occurs to any of the structures mentioned, then problems will occur with movement. And so in the case of neurological disorders like Parkinson's disease, the substantia nigra is damaged and is not producing enough dopamine, which results in slowness of movement and tremors. And now the last tract I'm going to talk about is in the cerebellum, which has 4 embedded nuclei that help them with motor movements. The first one is the dentate, which is planning and coordination of motor movements with the motor cortex and the basal ganglia. The second and third are the eboliform and the globose nuclei, which are responsible for unconscious proprioception and regulating movements for ipsilateral extremities. And the last is the vestigial nucleus, which is important for body posture related to the vestigial system. And then in patients with oropharyngeal dysphagia, the motor systems would not be able to detect errors in movement from feedback, which means the movements would not be controlled.